Good evening, everyone. On behalf of the Pfizer Oncology Medical Team, I welcome you all to day two of the Pfizer Genitourinary Tumor Conclave 2022. Today, we have with us eminent national and international faculty who will discuss key topics related to the management of renal cell carcinoma and the recent advances from the recent ASCO GU and the ASCO 2022. Now, to initiate the program, I would like to call upon the program director, Dr. Sadashivru, who is the head of Department of Medical Oncology at NIMS, Hyderabad. Over to you, sir.
Yeah. Dr. Ankita, you want to say something? Shall we go? So go ahead. No?
Sir, please, maybe we can start. Yeah.
Yes. So, good evening, everyone. Thank you very much for this invitation. Uh, it's a very warm, I think it's very rainy season now. I think it's raining heavily in Hyderabad as well as Mumbai also. Now, we would like to start our program. So, as you know, yesterday we had discussed more on urinary bladder cancer. Today we are going to discuss more about this renal cell carcinoma. Yes, exactly around 17 years ago, just when I joined in the medical oncology as a resident, one of our VIP or minister got some diagnosis of renal cell carcinoma. So he asked me, so do we have any treatment? At that point of time, 17 years ago, we had only interleukins and interferons. Now there is a sea change in the treatment landscape of renal cell carcinoma. We have many drugs, so we don't know which one to use first, how to choose the first one, again, how to sequence that one. I think now this is the best forum. I think we have the good speakers, good doctor, what is a panel members, and with enough experience. So we are going to have this good discussion today. Definitely, we'll end up with a good home tech messages. So I'd like to invite the first speaker of today is Dr. Mohit Agarwal. So he's a director and head of medical oncology in Fortis Hospital, New Delhi. So without wasting much time, sir, I'll hand over the podium to you. Dr. Mohit Agarwal, sir, please.
Good afternoon, everyone, and heartfelt thanks to the organizers for giving me this opportunity. And as we are, it is just to set the ball rolling, and I have been entrusted upon the job to talk about the current first-line management of advanced metastatic RCC. So, without wasting time, I would like to go on to the presentation. So, my presentation today would be laying stress on some amount of epidemiology of metastatic RCC in India, as well as I'll just be touching upon a bit of data because I'm sure that my subsequent speakers have much more to say about the data and basically what do the major international guidelines say. So, if I talk about the kidney cancer epidemiology, it is the 14th most common frequently diagnosed cancer worldwide. This was as per the Globocan 2018. And we had about 4 lakh new cases in 2018 and about 1,75,000 patients succumbed to it. So a very important aspect comes to the stage of presentation at the time of the diagnosis. So what is heartening to see here in terms of renal cell carcinoma is that at the time of presentation and at the time of the diagnosis, about 65% of the disease is localized and another 17% is regional. So if we talk about the loco-regional disease, it accounts to about 80% of the cases. The distant disease where the distant metastasis is there is only about 16%. And if we want to translate the similar data in terms of the 5-year survival, when we have the stage 1 and 2 disease, the 5-year survival is about 93%. It falls down to 70% the moment the disease goes on to stage 3, 4, but it is dismal 12% when it is distant stage 4. So this is how important the stage of presentation is. So this is the age standardized incidence and mortality rates of kidney cancer on the basis of gender on different continents. And you can very well see here that there is a slight male preponderance as compared to the female gender. The maximum number of cases are from the North America and Western Europe. And approximately 95% of all the kidney cancers are renal cell carcinomas. So if we talk about India, the incidence of renal cell cancer is about 2 per 1 lakh population in males and in about 1 in 1 lakh in females. And as per the Globocan 2020, kidney cancer is 14th leading cause of new cases and the 15th leading cause of mortality. Now in India, we have a specific trend in terms of RCC, what has been observed, and that is that it is more frequent in the younger population. About one third of the patients are seen to have an age less than 50 years, and only 10% of these patients have tumor size less than 4 centimeter. So that means that usually you have much more younger population over here presenting with this disease, and as well as the size of the tumor is bigger. And it has been seen that in patients who have less than 40 years of age, they have a relatively lower survival rates. So we can say that we are catering to a more aggressive disease in India. Now, as important as the stage is something like the risk group stratification, which is this international metastatic renal cell cancer database consortium known as the IMDC criteria. Very important criteria at the time of diagnosis, 6 criteria, which are namely time from the initial diagnosis to the treatment less than 1 year, Karnofsky performance score less than 80, hemoglobin less than the lower limit of normal, calcium above 10 milligram per deciliter, and platelet count and neutrophil count above the upper limit of normal. Each of these 6 factors carry a weightage of 1. And if none of them are there, the patient is characterized as having a favorable risk group. If 1 or 2 are present, it is the intermediate group, and more than 2, that is anywhere between 3 to 6, is the poor risk subgroup. Now, as we have seen in the various studies, about 75 to 80% of patients do fit into poor or intermediate risk, and but that also means that we have about 20 to 25% in the favorable risk group profile, and which is very important because you have various options like a single agent or even an observation in such patients. Now, a bit about tumor biology, and we all know that renal cell carcinoma is a very, very vascular tumor, and a VEGF has a very strong role in the tumor biology in this case. So how does the VEGF help? Well, increases the angiogenesis. The moment the angiogenesis is increased, there is an abnormal vessel growth. And since the vessel growth is abnormal, it leads to hypoxia, the infiltration by the immune cells is reduced, and intravasation and shedding of cells also occur. Also, there is immune suppression by inhibition of the cytotoxic T lymphocytes, you can see here. And this leads to recruitment and proliferation of immunosuppressive cells, and also increased expression of inhibitory receptors like PD-1. So maybe then the role of anything like a VEGF inhibitor along with the PD-1. So why do we, in present era, we know that the standard line of treatment tries to combine both IO with VEGF inhibitor. So why so? Because it has a dual action of inhibition, which would be normalizing the vasculature, hence the immune infiltration would increase. There would be better delivery of the anti-cancer therapies. The immune stimulation would be there in terms of the dendritic cell maturation, infiltration by T cells, reduction of the regulatory T cells, and reduced PD-L1 expression. And obviously, there is also a blockade of the PD-1 and the PD-L1, which would lead to a reactivation of T cells, leading on to some tumor-lytic properties. So this might be considered something like a synergistic effect by using both the molecules together. So this is basically all the first-line trials which we have, on the basis of which the first-line drugs have been approved in advanced RCC, mainly the IO-IO combination Ipi-Nivo, Axi-Pembro, or Len-Pembro, or the Cabozantinib. So these, I'll be just briefly touching on to them. So first is this trial of Checkmate 214 with the Nivo-Ipi combination, which was compared with sunitinib in advanced RCC. Now here I have presented the graph in the ITT population, and you can very well see here that PFS and OS are better in both the arms, and the OS is showing a significant value. However, the point to be noted down over here is that this drug is approved only in intermediate and poor risk, and not in the favorable risk, because in the subset of the favorable risk, this drug combination showed an inferior PFS and a similar OS. Hence, this is only to be used as per the guidelines in the intermediate and the poor risk stratification group. Now, one of the most common combinations I think being used worldwide is the combination of pembrolizumab with axitinib, and this was on the basis of this Keynote 426 study, which compared it with sunitinib in advanced or metastatic RCC. This is the graph in ITT population, and you can very well see that the two graphs are very well separated in the favor of the combination arm, and this was clinically and statistically significant as well. Also, this combination is actually approved in all the risk subgroups, be it the favorable, the intermediate, or the poor risk subgroup. So if we talk about the intermediate and poor, the results are still better. The hazard ratio is 0.63, translating into a benefit of 37%. While in the case of favorable risk, the graph is overlapping. So the OS benefit is not there, which is not clinically significant. However, there was a numerical improvement in the PFS. The third combination is this nivolumab along with cabozantinib with sunitinib comparison in advanced or metastatic RCC. The approvals are same like the pembrolizumab and axitinib, where you have approval in all the risk stratification subgroups. And if you see the ITT population, again, it has shown a meaningful benefit, which is clinically significant. So if we talk about this poorer subgroups, as we go on to the poorer subgroups like the intermediate and then to the poor, you see the graphs are again separating widely in the favor of the combination arm. That means the high risk patients tend to benefit much more. But when we come on to the favorable risk, again, in terms of the OS, it is again the overlapping graph, and only the PFS benefit is in the terms of the numericals. And lastly, this combination of lenvatinib and pembrolizumab, which has been compared with everolimus and sunitinib, and you can again see that in the ITT population, this combination has been shown to have an improvement which is clinically significant. And if we talk about the patient subgroups, you would very well again see here that in the intermediate and the poor risk subgroups, as per the IMDC, the combination arm is doing better. However, the moment we go to the favorable, it shift towards neutrality. A very important slide which I tend to present in my presentation is this time and onset of toxicity grade of immune-related adverse events in patients with PD-L1 antibodies, because these drugs we all know have a tendency to produce some immunological effects. So we should know at what point of time, what do we expect, and when does this actually nadir and tapers off. So it usually starts at 4 weeks when we can have these skin reactions, but then we can have something like a colitis, liver toxicity, neurotoxicity. The important one is the pneumonitis, which starts at about 10 weeks and completely tapers off at 20 weeks. So these things should be noted at the time of giving these drugs, at what patient is presenting clinically, so that you can actually see whether it might be due to this immunological adverse events. So this is how we have evolved in terms of the treatment, as Dr. Sadashiv was just saying. Way back in 2009, it was TKI. We have built onto the TKI also. Initially only sunitinib, then pazopanib came, tizovinib and cabozantinib. Then somewhere in 2019, and this IO combination, and now the first frontline management is the combination of IO TKI, which are, and some of these are still evolving, like something like an avelumab, axitinib, which is not approved in the preferred regimen, but the data is still evolving. This is again the chronological order of the of the development of the monotherapies, which was sunitinib, then somewhere pazopanib, tizovinib, and cabozantinib, and again how the IOs came into the fray, and then something like also some studies about the avelumab and axitinib. So coming on to the guidelines, if we talk about the guidelines, most of the guidelines take into the factor consideration favorable and poor and intermediate. The regimens are slightly different for the favorable, and they are usually similar for poor intermediate. I'll be talking about the preferred regimen. So if you can see very well here, the top 4 regimens which I've already talked about are all given in the favorable counterpart. However, the IO combination is not given because of the reasons I have already told. And also the oral TKIs can be used like pazopanib and sunitinib. Well, when we move on to poor intermediate, all the 4 drugs which for combinations which we have discussed can be given, and also the option is a single agent cabozantinib. When we talk about ESMO, again favorable, they approve of only 2 combinations, which is axitinib pembrolizumab or cabozantinib nivolumab. While intermediate and poor, then we have all those combinations we have already talked about. And when we talk about EU guidelines, again it is similar to sort of an NCCN guideline only, where they have just removed the TKIs from the preferred regimen and just concentrated on the combinations. So these are some of the sequencing possibilities which might be evolving. And we know this IO combination, which is coming, has a very good CR rate and which tends to persist. So it has been proposed that in 30% of patients who are candidates for cytoreductive maybe this combination followed by cabozantinib would, and then subsequently going on to further lines, can be one of the sequencing possibility. as this way you have some other sequencing possibilities as well. I'm sure my subsequent speaker is going to put some light onto this. So, in conclusion, these IO combinations are a new standard of care in first-line metastatic renal cell carcinoma, and IO and TKI-IO are different, have different benefits and risks. Therapies needs to be individualized to the patient, to the need of the patient, seeing the comorbidities, seeing the risk stratification, and differentiation between TKI and IO-driven adverse event is key to the successful management of combination therapies. And therapy management is integral to optimization of the outcomes. Thank you. And with this, I would like to hand back to the organizers.
Thank you very much, sir. As you said, you set the ball rolling. I think you prepared a very nice ground to just, I think everybody they can play in a safer way now. I think they have very good ball set rolling. So, I think we'll have the discussion later. Now, I would like to invite our guest speaker today, Dr. Enric Grande. I think he's one of the best speakers I have heard, and I think he just now we discussed 7 years ago he came to Hyderabad. I think he had arranged one master class in RCC. I think he's a director of the medical oncology program and clinical research lead, MD Anderson Cancer Center, Madrid. So he has many publication on his credit and many awards, but I think I don't want to go in depth of that one. I think I'd like to invite Dr. Grande to, sir, this is your podium is yours now. Thank you very much.
You are very kind, and I don't really deserve that words to me. Well, thank you so much. This is a privilege for me to be here with you, although, well, I would love to be physically there in India. Well, you are all invited to come to Madrid whenever you want to come. So you will be my guest, and I will do my best to make you feel happy. Well, my task today is very easy because Dr. Agarwal has done a magnificent review of the current data that we have with the combos, double IO or TKI plus IO in the first line setting. So what I'm gonna try is to try to translate this data into the daily practice. So what this data are really meaningful for the patients that are facing in the real world setting. Okay. So before starting, once again, I want to thank Pfizer, particularly Ankit and her team, for kindly inviting me once again to these Indian meetings. I'm delighted to be here with you, and this is very easy to work with you. Thank you so much. Okay, well, Dr. Agarwal mentioned these guidelines before, NCCN guidelines, and take a look at the version. This is version number 1 from 2023, so they are really working ahead of time. So, okay, this is the current scenario that we have. Well, you are facing a patient in your clinic, well, you have many doubts. And in these doubts, don't forget that one of the options that we have is active surveillance. Do you still considering active surveillance in your daily practice for patients with metastatic renal cell carcinoma? When you have available tyrosine kinase inhibitors, immuno-oncology drugs, combinations of both, offering for overall survival, response rate improvement, progression-free survival improvement, and also quality of life improvement. This is very, I think, not easy to identify those patients in the clinic, but it's okay. This is still there in the guidelines, including interleukin-2 high doses. Well, you need to be very brave to offer interleukin-2 high doses so far to these patients. Another option, and I think could be something reasonable in some small proportion of patients, is they offer a TKI as a single agent. Well, we have sunitinib, we have pazopanib, we have cabozantinib approved in this field in the first line setting. So why not offering one of these drugs as a single agent could be? But we have also the combinations, the most fashion combinations that we have in the field of RCC. We have double IO combo, nivo-ipi, and we have up to 4 possible combinations based on TKI plus immunotherapy, pembrolizumab, avelumab, cabo-nivo, and also pembrolizumab to offer to our patients. So let's try to put this clear in our mind. Okay, first, and Dr. Agarwal did this summary before. Okay, where are we coming from in the field of first-line renal cell carcinoma treatment? Well, we are coming from the cytokines era. And in the cytokines era, don't forget that this is not too long away. This is just 10, 12, 13 years from now. So at that time, our patients were only living, or the expectancy of living of our patients was less than 1 year. Less than 1 year. With the use of tyrosine kinase inhibitors, and with the use, I would say, with sequential use of tyrosine kinase inhibitors, the median expected overall survival for patients with metastatic renal cell carcinoma reached up to 2 years. So we doubled the figures, both in the clinical scenarios, in the clinical trials, and also in the daily practice setting. We can see patients that are long-lasting survivors. This is also true, and probably you have experience with that in the cytokines era. Okay, there was 10% of the patients, long-lasting survivors, those patients in which we thought that high doses of interleukin-2, combinations of interferon plus interleukin-2 were really good working at that time. Okay, do you remember in this era what was the clinical profile of these long-lasting survivors? If you remember well, those patients, young patients with very limited metastatic size of the tumor, so low tumor volume, particularly those patients with only lung metastasis or only lymph nodes metastasis at that time, very good ACOG performance status, very good renal function, very good liver function, very good everything. So this is exactly the same patient profile than the patient profile we are now calling, according to the Hens criteria or IMDC criteria, the favorable risk. And we know that included in the favorable risk subgroup of patients, we have long-lasting survivors, no matter if we are offering them for tyrosine kinase inhibitors or new combinations. So be careful when thinking that cytokines can be today an option to treat these patients. I am a better doctor than I was 10, 15 years ago. I'm saying that because tyrosine kinase inhibitors and mTOR inhibitors, allow me to develop myself, my career as a medical doctor. Why I'm saying that is because of the side effects. It's because of that we needed to learn how to deal with the side effects of tyrosine kinase inhibitors and mTOR inhibitors. Don't forget about the hypertension, diarrhea, skin rash, hypothyroidism, fatigue, asthenia, loss of weight, loss of appetite, all of these family-related adverse events that are together with the use of tyrosine kinase inhibitors. So we learn a lot of things, and we offer for some a clinical benefit, I would say a high clinical benefit to our patients at that era, the tyrosine kinase inhibitors, the angiogenesis era. And now we are entering into the new combinations era based on immunotherapy. And immunotherapy has completely changed the game. Completely changed the game. Why is that? It's because immunotherapy combos are impacting in all the endpoints that we have in oncology. First, they are impacting in overall survival. Now our patients are living longer than 3 years, 4 years, 5 years in the recent scenarios that we have. Overall survival impacting. They are also impacting in the quality of life, related with the greatest response rate and with the longest progression-free survival. So the 4 major endpoints that we have in oncology, they are all met by the new combinations in this field. Okay, so we know that. How can we translate this data? Why these new combos are important in daily practice? It's because I don't know 2 patients with renal cell carcinoma, with metastatic renal cell carcinoma, that they behave equal. They behave equal in terms of histology, in terms of volume, tumor volume, in terms of locations of metastasis, in case of should I do nephrectomy, cytoreductive nephrectomy or not, in terms of tolerability to the drugs that we are offering, and in terms of what is the clinical goal I have in my patients, on each of my patients, I would say. Because if you take a look at these 2 patients with metastatic renal cell carcinoma, probably your clinical goal when you are deciding what treatment should I offer, probably would be completely different. The one that you can see on your left, probably, because of the size of the volume, because of the symptoms this patient, normally has, probably I need a deep, good, and rapid tumor shrinkage. And this response, radiological response, should be the driver in terms of making the decision of which option should I offer to the patient. However, take a look at the patient that you have on the right. Take a look at these micronodules in the lungs. Do you think this patient is going to have any symptoms? Do you think it matters the volume of the metastasis? Do you think this patient, the survival of these patients is conditioned by these micronodules? In the short term, of course. Well, probably your clinical goal, your clinical endpoint when facing this patient in the clinic probably could be something completely different. And responses, tumor shrinkage, why you need that? Okay, to achieve a radiological complete response, this is very fashion, this is very sexy, and we love to get that kind of responses. But probably this is not the major goal that this patient may have. Probably the patient on your right, probably preserving, maintaining the quality of life should be our goal. Because the quality of life of the patient on the left with the highest tumor volume, probably this is condition of the volume of the metastasis. And if we want to improve the quality of life, we want to reduce the volume. But in the patient with micronodules in the lung, why do you think a response is gonna change the quality of life because of the size of the volume? Well, probably, and definitely, I would say no. Why it is that important? Take a look at the data we saw at last ASCO meeting just 1 month ago. Well, those patients, no matter if you are offering for immunotherapy, double IO, nivo-ipi, or you are offering for single agent TKI, those patients that are responding, no matter if the response is coming from the TKI or the immunotherapy, are experiencing better quality of life. The deterioration of the patient is delayed. So response is important in oncology, but preserving, maintaining, or if possible, to increase, improve the quality of life, this is even better. So if you have this kind of responses, this kind of balance in between the efficacy and toxicity is extremely important to balance in your daily practice. And this balance of efficacy and toxicity is something that you think yourself before offering any treatment to your patients with renal cell carcinoma. And this balance probably is different, the balance that you have, each of you have in your clinic, than the balance that I have in my clinic. Like everything happens in the real world. So you can be more aggressive than me, or you can be more, I would say, coward, like me. I am very coward. So you can balance in one patient the efficacy ahead of toxicity, and in the other patient, you can balance the toxicity ahead of the efficacy in the clinic. Let me give you a couple of examples. These are the data from the CLEAR trial. And Dr. Agarwal mentioned this data before. Okay, this is the data of lenvatinib pembro versus sunitinib in intermediate poor and favorable risk. Amazing data in terms of progression-free survival, probably the best in terms of efficacy data that we have in renal cell carcinoma. Magnific response. This is great. However, take a look at the toxicity when using lenvatinib here. Take a look at the grade 3 time of onset of these grade 3 or higher adverse events with lenvatinib. Take a look at the hypertension, proteinuria. Okay, you can say, okay, hypertension, proteinuria, the patient doesn't really realize of these adverse events, which is great. This is not conditioning the quality of life, but skin rash, mucositis, fatigue, musculoskeletal pain, diarrhea, decrease of appetite, weight decrease, nausea. Take a look at the severity and take a look at when these adverse events are coming. So, okay, you have a very good combination. Lenvatinib pembro is probably the most active combinations that we have. And you know, I am not using lenvatinib pembro in my daily practice, only for a very selected and restricted subgroup of patients with very high tumor volume, very young patients, in which I think, well, probably and definitely these patients will not have a second opportunity. So we need to balance the efficacy in one hand and the toxicity in the other hand. So this is not just a matter of offering the most sexy thing, the most sexy combination that you have to your patients. We need to balance efficacy and toxicity when making this decision. I think it is important because we saw that the efficacy is sometimes linked with toxicity. And you have the options to offer for axitinib as the TKI, I would say my preferred TKI, to be combined with immuno-oncology drug. And this is because of two things. First thing, how potent and selective anti-angiogenic inhibitor axitinib is. Probably the most potent and selective tyrosine kinase inhibitors that we have. This is the first reason. Second reason, and probably the most important one, the short half-life, median half-life in plasma of axitinib versus the other tyrosine kinase inhibitors available in this field. Take a look at this because it has a clinical translation. This pharmacology is telling us that you need 5 times the median half-life in plasma of this tyrosine kinase inhibitor to get the grade 3 and 4 adverse events to disappear, to get the drug to disappear from the plasma of the patients. So it is important, definitely it is, because if you have a grade 3 and you stop today the tyrosine kinase inhibitor, with axitinib you only will need 2-3 days to stop to reduce the severity of these adverse events. However, if you have lenvatinib, pazopanib, sunitinib, cabozantinib, it will take longer to resolve, to overcome this grade 3 toxicity. So this is why it is extremely important to bear that in mind when combining tyrosine kinase inhibitors plus immuno-oncology drugs, particularly for these overlapping side effects that TKI and immuno-oncology drugs may have. I'm speaking about rash, skin rash. I'm speaking about hypothyroidism. I'm speaking about mucositis, fatigue, in which, and particularly important, diarrhea, in which, well, you don't really know from the clinical perspective which one, if the TKI or the immuno-oncology drugs, is the agent that is really providing these adverse events to the patient. If you don't believe me, take a look at this recent data published by Brian Rini, in which they show that combinations based on axitinib plus IO, avelumab, pembrolizumab, the time to resolve the grade 3 and 4 toxicity is much, much lower than when using another TKI or than when using another combination based on immunotherapy. What am I doing in my practice? Well, for those patients with favorable risk, well, probably favorable risk histologies, well, angiogenesis is playing a huge role in the molecular mechanism. So this is why, okay, active surveillance, I'd say that you need to be very brave to offer active surveillance or to offer a single agent TKI to your patients. But particularly for me, in this balance in between efficacy and toxicity, axitinib plus pembro or axitinib plus avelumab are my best and preferred options to deal with the patient. Why? It's because of the efficacy and particularly because of the toxicity in a long-term manner. If you are facing a patient with favorable risk histology or one adverse prognostic factors by hen, probably the time on treatment during the first line you want to choose would be longer than 1 year. So you need for very well-tolerated tyrosine kinase inhibitors to be combined with immuno-oncology drug. Okay, feel free to use immuno-oncology drugs there, but with a very well-tolerated tyrosine kinase inhibitors. These are the data from the Javelin Renal 101, in which avelumab was compared with sunitinib, particularly in the favorable risk. Take a look at the hazard ratio, the magnitude for the benefit in terms of progression-free survival, 0.5, which I think this is extremely important. And take a look at the toxicity in terms of, okay, the median PFS, the overall response rate is consistent with avelumab regardless the age of the patient. So if you have a combination that is well tolerated, well, this is extremely good, particularly for those elderly guys that you all are facing in your daily practice. This is why it is important. If you are facing this lady, 57 years old lady, no comorbidity, partial nephrectomy when she was 42 years old, so 15 years before, PD-1 clear cell histology, well, incidental diagnosis of 7 micronodules. This is the largest one that you can see in the CT scan of the patient. ECOG 0, good risk according to the IMDC criteria. Well, do you really need for tumor syncreage? Do you really need to offer for lenvatinib to this patient, lenva pembro? But I have 70 plus % of response rate by RECIST criteria. This is great. Cabo-nivo. Do you really think cabozantinib with the diarrhea grade 3 and 4 toxicities, or skin rash, or asthenia, or hypertension that cabozantinib may have. Okay, cabo-nivo, this is great in terms of activity, great combination. However, do you really think that this lady with 57 years old merits to be treated with this kind of combinations based on this kind of TKIs? Well, which is the expected median overall survival for this lady only with a TKI? 43 months. 43 months. Probably the median time on treatment with a TKI, with a single agent TKI, would be in between 12 to 14 months. So you need very well and better tolerated tyrosine kinase inhibitors to be combined in patients with favorable risk. And what can we do for patients with intermediate and poor prognosis? Well, I have clear in my mind two scenarios in which I think nivo-ipi is the best strategy that we should offer. First scenario, patients with sarcomatoid component or sarcomatoid tumors, in which we know that the angiogenesis gene signature is lower and the PD-L1 expression is higher. So probably these patients with sarcomatoid features is the ideal scenario for nivo-ipi. Second case scenario, well, take a look, particularly if these patients with sarcomatoid component, they have PD-L1 positive tumors. Take a look at the proportion of patients alive or without progression after 5 years. 5 years. This is something that that TKI single agent cannot really offer. And second scenario, patients that are demanding you for curation. And know that we cannot offer curation for our patients with metastatic renal cell carcinoma, but some of our patients are demanding to be cured. Okay, you have one option, and the option is to be one of these long-lasting responders to double-IO immuno-oncology drugs. Well, if you are facing a patient with metastatic renal cell carcinoma, if this patient is demanding you to be cured, okay, you have the options to offer for nivo-ipi. Less chances of responses, only 40% compared with 50 plus, 60 plus, or 70% with a combination of TKI plus IO. Okay, lower chances. I would say 40% less chances of responding. But if your patient has a clinical response were treated with nivo-ipi, the possibilities to be a long-lasting responder is very high. Particularly, take a look at this median follow-up time, 4 years. Take a look at the last part of the curve. Those patients with intermediate and poor risk, those patients in which other options probably will fail immediately. If the patient is responding, take a look at the duration of the response. This is for me practice changing if the patient is asking for a curation. Because you need to, counsel this patient that probably the tumor will progress sooner. And probably most of the patients will be progressing. This is the opposite that what happens when you are offering a tyrosine kinase inhibitor plus an immuno-oncology drug. Where I am positioning nivo-ipi? Well, nivo-ipi is positioned in the intermediate poor risk, same that cabo-nivo, lenva-pembro, in which you have high volume of disease. Okay, what can we do for those patients with 2 or more adverse prognostic factors by Henn criteria? Think yourself, what would you do in this patient scenario? 63 years old, hypertension, chronic bronchitis as the relevant medical history, nephrectomy 3 years ago due to clear cell renal cell carcinoma with 20% of sarcomatoid component, PT2 tumor. In the follow-up, 3 years later, it was noted liver, take a look at the size of the liver metastasis, and bilateral lung metastasis. ECOG2, neutrophils higher than the upper limit normal. So this is an intermediate risk IMDC criteria, 2 factors. What would you offer to this patient? Liver metastasis, take a look at the size of the liver metastasis. Do you think these patients will have a second opinion? They may a second chance to be treated in the second line setting? I don't know. So probably you need an active treatment. It will depend on what the patient wants. The patient wants to be cured. The patient wants to be stable. The patient wants to be, to have the options to respond, and let's see what happens. The clinical goal that you have in the clinic to treat this patient, probably is different. And take a look at the proportion of patients not that are responding, the proportion of patients that are progressing. Because, do you remember the size of the metastasis in the liver? If the patient progresses, probably you will not have any patient for the second line treatment. So it is also important not only how many patients are going to respond in the CT scan, but how many patients will not progress as the best response in the CT scan. And when you are thinking about that, TKI plus IO combos are better, definitely, than a nivo-IP in this scenario. Take a look at this clinical scenario number 2, and take a look at the age of these patients, 86 years old man. Take a look at the comorbidities, hypertension, diabetes, heart attack 2 years ago, ECOG 2. But take a look at the volume of the metastasis. Hematuria, PT4, N2, M1, clear cell carcinoma, anemia, platelet levels elevated, poor risk because of 4 adverse prognostic factors. Very poor risk patient, I would say, and very frail patients, elderly and frail patients. Okay, but what would you do? Best supportive care could be an option. Active surveillance could be an option. But you know what is going to happen with active surveillance and best supportive care? Probably this patient will die shortly, in less than 2, 3, 4 months. Okay, if you have the options to offer for the new combinations, what options would you offer? Do you think an older guy, 86 years old, with these comorbidities will tolerate well lenvatinib, cabozantinib? Probably not. Probably axitinib could be a good option. Probably axitinib, avelumab. These are the data from the Javelin 101. Well, take a look at the efficacy in terms of progression-free survival in patients with poor risk. Okay, you can see, okay, median PFS is only 6 months, but this is better than 2.9 months with sunitinib only. Has a ratio of 0.5, which is not bad. Well, I think this is an option, probably the best tolerated options that this patient may have. Take a look at this other scenario, 57, very young patient, ECOG 1, no relevant prior medical history, hematuria, and this hematuria, take a look at the thrombus in the vena cava. This hematuria is conditioning for the diagnosis of these patients with a PT3V, the tumor is invading the vena cava, clear cell carcinoma, with a thrombus in cava, lung metastasis, anemia. So this patient has 2 IMDC adverse prognostic factors. What would you do here? Okay, would you dare to do a cytoreductive nephrectomy? Okay, you can do that, but this is against the guidelines. Because take a look at the data of the Carmina trial, those patients with 2 or more adverse adverse event factors from IMDC are the ones that are going less well when offering for sunitinib. So be careful in operating, be careful in offering cytoreductive nephrectomy to patients with 2 or more HENS criteria. This is my last slide. The multidisciplinary team decisions are key here, and the urologists are taking part not only of the cytoreductive nephrectomy or the nephrectomy at the diagnosis of the patients, they are taking also part of the metastasis removal and also taking part of the deferred cytoreductive nephrectomy that we are performing so far in our patients with metastatic renal cell carcinoma that were not candidates at the beginning, but because of the high efficacy of the new combos that we have, they are becoming resectable when the longer follow-up. Thank you so much to all of you for your attention.
Thank you very much for a wonderful talk on upfront therapies. I think this how to choose based on this risk stratification. Very nicely, you have put something like in a good intermediate risk and poor risk. Really, it's a very exhaustive and very informative lecture. We'll have the questions in the panel. So time being, so I would like to now invite Dr. Amit Joshi, sir. I think he's doesn't need an introduction. I think, but still, he's a professor in the Department of Medical Oncology, Tata Memorial Hospital. He's very much interested in genitourinary cancers and specialty. Over to you, Dr. Amit, sir.
For today's presentation is second line. So there are 2 scenarios for this situation. First is the post first line TKI, that the patient has received the TKI, that is sunitinib, pazopanib in the first line or sorafenib in the first line, and then patient has progressed, which is this is the most common pattern which is seen in our current practice. The second scenario, which is rapidly evolving, that the patient has received either a combination of IO plus IO or a IO plus TKI and now has progressed. So the treatment options varies from what the patient has received in the first line of therapy. So this is the importance of this. This is one of the very important slide. Can you go back to previous slide? So this is the slide showing the importance of the various lines of therapy. So in this, there are 2 curves. The red one is showing the patient who has received the third line and beyond therapy, and the blue line, which is patient who have not received third line and beyond. And if you see the survival, the patients who have received third line and beyond, the overall survival was in the range of around 15 months, and patients who have not received third line, the survival is range of around 7 months. So that means if we are able to deliver multiple line of therapies in a RCC, especially the clear cell RCC, definitely there is an increase in the survival, and the patient will live for a longer period of time. And with the availability of the multiple therapies, some patient may even go for a fourth line of therapy. So that means whenever there is a possibility of delivering further line of therapy, we should try to give them the optimization or sequencing of the therapy in RCC is very much important. So the first scenario which I discussed, that is the post first line of TKI, that the patient has received the first line of TKI and now the progress. So what are the standard options? So as previously discussed, and we all know, the options varies from the mTOR inhibitor, that is everolimus, axitinib, the nivolumab, the MET inhibitor cabozantinib, the combination of lenvatinib plus everolimus, and then sorafenib. So these are the various options which we can consider when the patient progresses over first line of TKI. We will quickly discuss all of these options one by one with the pros and cons of each options. So this is the record one trial. This was the study of everolimus versus placebo in patients who have progressed over first line of TKI. They received the either everolimus 10 mg per day, or they received the placebo plus best supportive care. Coming to the result of this study, next slide please. So nevertheless, this trial has shown that whenever the patient who progressed over first line of TKI, when they receive the second line everolimus versus compared to the placebo, the patient who received everolimus has a better PFS compared to the patient who received placebo. Although the OS of this trial doesn't favor, but there was a lot of crossover in this study. Patient who were on placebo received the everolimus on the progression. But definitely this trial has established the everolimus as the second line of therapy in patients who progressed over first line of TKI. So I think this what I discussed, that patient who received the everolimus has a better PFS compared to the patient who received the placebo. However, the overall survival, which I told you, was not significant because of the extensive crossover. So this was I discussed that because of the extensive crossover, the OS was not affected. So with the result of this study, the record one, the everolimus has become, and definitely this drug has its own side effect profile. The stomatitis, next slide, the stomatitis infection are the most common side effects which we've seen. And apart from the laboratory parameters like the hypercholesterolemia, lipid abnormality, the sugar abnormality, that was more common in the everolimus. Although it was approved, but definitely majority of the patient find it difficult to continue this therapy. So even there was approval of this everolimus, but definitely majority of the patient have some or other grade 3-4 toxicity. Then comes the next axis study, where they compared the axitinib in second line patient who received first line TKI. When progressed, they receive either axitinib 5 mg compared to the sorafenib, which was supposed to be the standard care at that point of time. So it was a trial of axitinib versus sorafenib in patient who received first line of TKI. So coming to the result of this study, the end point of the study was the PFS, and this trial showed that the patient who received axitinib in second line had a better PFS of around 7 months compared to the patient who received sorafenib in the second line. So it was around 3 months PFS benefit in favor of axitinib compared to the sorafenib. As we all know that this axitinib has its own associated toxicity. The diarrhea, the most important is the grade 3 hypertension. Apart from this, the is well tolerated. The incidence of proteinuria and the hypertension was slightly more in the axitinib arm compared to the sorafenib arm. And as expected, the hand-foot syndrome was more common in the sorafenib arm compared to the axitinib. But since the primary endpoint of this study was a PFS, when patient crossed over, this trial has not shown the OS benefit of axitinib over sorafenib, but still this drug got approval on the basis of the PFS benefit over sorafenib in second line TKI. Next comes the drug cabozantinib, which is the compared with the then standard of. So by this time, the everolimus and the sorafenib were considered to be the comparator arm of the any newer trial for second line. So when this trial was planned, the method trial, the cabozantinib was compared with the then standard of care of everolimus in second line. So patient who progressed over the first line of TKI, either one line or two line, they were divided into two groups: cabozantinib 60 mg versus everolimus 10 mg. The primary endpoint of method study was the PFS, and secondary endpoint was OS and the overall response rate and safety. So coming to the result of this study, if you see the various risk stratification patients in the favorable versus intermediate, this study has a quite a lot number of patients of the intermediate and poor. That means the patients who have a real bad biology diseases. So around 60% patients have an intermediate, are in the intermediate and poor risk group of this trial, and this was equally divided. And if the second line, more than two line of therapy were received, so that means this cabozantinib was tested in a more advanced group of the patient, and about one third of the patient have received more than two lines of therapy in the first line. And the at that point of time, various standard first line sunitinib, pazopanib, all were equally distributed between the cabozantinib versus everolimus group. So coming to the primary result of this, PFS was the primary endpoint, and there was a clear-cut benefit of 7.4 months versus 3.8 months in favor of cabozantinib, and this trial achieved the primary endpoint of this study. And similarly, next slide, please. Not only the PFS benefit, this trial has also shown there is a clear-cut overall survival benefit in terms of cabozantinib. This was around 1.4 months in the cabozantinib versus 16.5 months in the everolimus arm. So not only for the PFS benefit, but also there was a OS benefit in patients who receive cabozantinib in second line compared second or third line in patients of clear cell RCC compared to the everolimus. Coming to the side effect profile, as expected, the cabozantinib is a more potent VEGF inhibitor with other associated of the hypertension. These are the grade 3-4 toxicity. If you see the hypertension, diarrhea, and HFS, all were more common. It's around 15%, 13%, and 11%. So that means increase of PFS and OS was at the cost of little bit toxicity in terms of hypertension, diarrhea, and HFS, which was in the tune of around 15 to 20%. So this is one of the important slide. Even in the approved dose is around 60 mg per day for this study. But if you see this study, the dose reduction was required in around 60% of the patient. So closely 2/3 of the patient has some or other form of dose reduction. So the average daily dose, if we reduce, it was around 40 mg, 43 mg. So in some part of the world, and we also generally in patients who are not very fit, we may consider for a 40 mg, not 60 mg, because we know that 2/3 of the patient who is not of good PS, starting on a 60 mg might be a little bit difficult. And this trial, even very controlled environment, has shown that 2/3 of the patient has some sort of dose reduction, and the average daily dose was around 43 mg. So that means in patients who are not very fit, we can consider for starting with a lower dose and increase the dose later on if the patient is tolerating very well. So with this availability of the data, with mTOR, the cabozantinib also got approval in the second line of therapy. So by this time, there are 2 or 3 drugs, that is everolimus, sorafenib, axitinib, and cabozantinib were approved. Definitely the everolimus and sorafenib was pushed to third line, and axitinib and cabozantinib were the important second line therapy at that point of time. Then comes the real game changer in RCC, the second line nivolumab, that is checkmate 025 data. This was the first paper of this was presented in around 2016 to 17. Then this was further 5-year follow-up. So in a second line therapy, this was a real achievement, that a 5-year follow-up data for a nivolumab in second line was published, and this was presented in around 2020. The result of the next slide, please. So this immunotherapy, that is nivolumab, have shown that even in second line, some patient will cross to the 5-year mark of a survival. So therefore, this 5-year data was presented in 2020. So this was the study design where the patient received either nivolumab in second line, that is immunotherapy, or everolimus, which is considered to be the standard of care at that point of time. So nivolumab versus everolimus, and we all know that patients were well balanced. Majority of them are in the favorable or intermediate risk group, and the first line and second line therapy was around 72% versus 28% in both everolimus and the nivolumab group. So patients were well balanced, and majority of the patient have a favorable and good risk at the time of initial disease presentation. Coming to the result of this study, so if you see the various time period survival, the 2-year survival was around 42 versus 52%, and there was a clear-cut separation of the curve from the beginning, and this separation of the curve persisted at the end of the, if you did 60-month mark, around 26% patient were alive at the 5-year follow-up compared to the around 18%, and this was despite the crossover of the study. So that means the patient who received second line immunotherapy early in their course, around 1/4 may are still alive even after the 5 years. So this was a very important publication data at this point of time, that if you offer second line TKI, second line immunotherapy on the progression of a first line TKI, around 1/4 patient may remain alive after the follow-up around 5 years. So this established the role of a nivolumab in second line with a long-term follow-up around 5 years. So I think this is another slide showing the complete response and all that. And we all know that all group of the patient benefit, and some patient may achieve a long-term control rate with the nivolumab. So regarding the response of the treatment, around 1 in 4 patients experience some sort of objective response with nivolumab, and this response was very minimal in patient who received. So not only is the PFS and OS benefit, it is the response rate which was also seen more commonly in the nivolumab compared to the everolimus. And the magnitude, if you the magnitude of benefit in terms of intermediate and poor risk, definitely the poor risk group patient benefited much more compared to intermediate and good risk benefit. So the patient who are in poor, previously the VGF in not be a very in a poor risk patient, that patient in a poor benefited more with the immunotherapy compared to the patients who are intermediate and good risk. So I think safety, we all know that the treatment related adverse effect, the immune related was more common. But if you see the overall toxicity grade 3 report, it was around 40% in the everolimus compared to the only 20% in the nivolumab group. So it not only it improved the survival as per the patient's side effects, this was more tolerable, and patient who received nivolumab had less side effect compared to the everolimus. Even the long-term health-related quality of life data, it suggests that the on a longer-term follow-up, the nivolumab has a better health-related quality of life compared to the everolimus. So not only the survival, it was also the quality of life which was improved with the nivolumab compared to the everolimus. The next, I think we can skip this slide. Go to them. So this is one of the slide which is showing that in some patient treatment beyond progression has helped. So in patients who are just have a minimal progression of the disease, in clinical practice we tend to continue nivolumab beyond the progression. So I think at that point of time, the nivolumab will have become the standard of care. But by the time this phase 2 data of a combination of lenvatinib plus everolimus versus lenvatinib alone versus everolimus alone. So this was a 3-arm study of a combination of a mTOR inhibitor plus TKI versus TKI alone versus mTOR inhibitor alone. So this study was, though it was a phase 2 study, but it definitely answered a very important question in second line RCC. So this trial has clearly established that patient who receive lenvatinib plus everolimus has a better PFS of around 15 months compared to the 7.4 months of a patient who received lenvatinib alone compared to the around 5.5 months of everolimus. So this established the combination of a len plus evro in a second line RCC compared to the either len alone or everolimus alone. So the longer follow-up of this trial has also established that not only the PFS benefit with the combo of lenvatinib plus everolimus, but there was a clear-cut overall survival despite the crossover in the subsequent line therapy. The median OS from the second line of therapy of starting with combination of len plus evro was around 26 months compared to the 18 months of the lenvatinib or everolimus arm. So this has established lenvatinib plus everolimus as a standard second line therapy in a management of clear cell RCC. So is there any optimum sequencing of therapy in second line? Next please. So the answer is that no, there is no optimum sequencing. Nobody knows what is the best strategy to follow. So this is the problem of too many options. What these studies did, it pushed the everolimus and sorafenib and beyond category. So the everolimus or sorafenib is not used in second. Which one agent to be used, that will depend upon the specific toxicity and of the individual agents. So if we compare, there are two most common agents, that is cabozantinib and nivolumab. So if we compare side by side the cabozantinib versus nivolumab study, only issue of a nivolumab with progressive disease as the best response, that we all know that is the problem with the therapy, that patient doesn't. Those who respond will longer period of time. Of cabozantinib, this was the progressive disease was as a best response was seen in only 14% patient. There was PFS, but this was not very well documented in the nivolumab. But the OS benefit was markedly different in the nivolumab compared to the cabozantinib. Most patients who are benefited are in the good and intermediate risk, while the magnitude of more in the poor risk group of the group. Elderly patient benefited less in nivolumab to the all ages patient we benefit with cabozantinib. The toxicity was slightly more in the cabozantinib compared to the. So in conclusion, first line nivolumab, cabozantinib, lenvatinib plus everolimus demonstrated superior efficacy to the everolimus as a mono. So nivolumab has the best safety and survival. Unfortunately, there is no direct comparison of a immunotherapy with the TKI, cabozantinib, or axitinib, or len plus everolimus. So in patients who receive first line of TKI, the second line of therapy, there are 3 or 4 options, which includes the cabozantinib, the axitinib, the pembrolizumab, the everolimus plus lenvatinib and nivolumab. Among all those, the nivolumab has a best overall survival with a long-term survival data. If patient is otherwise fit, the immunotherapy seems to be some edge over other therapy. So this was the patient who received the TKI in the first line, and these are the some studies when the patient have received the IO plus IO or IO plus TKI. Then what are the our options? So this is one of the phase 2 study of a pembrolizumab plus lenvatinib in second line therapy of RCC post PDL1 and CTLA. So if the patient has received especially the IO plus IO combination in first line, that is nivolumab plus ipilimumab, then what are the other options? So this is the study, our phase 2 of a lenvatinib plus pembrolizumab, and the primary endpoint of this study was objective response rate at 6 months in interval. So this trial had shown that patient who received first line IO plus IO or IO plus TKI, if they receive the pembro plus lenvatinib, there is some data which shows that there is a definite benefit in the progression-free survival, and there was a benefit in the survival also. So this was the one of the combination which has the other newer drug which is not available in our country, which has been used in this combination is the tivozanib. This is another TKI with a some more a target of inhibition. So this was a phase 3, TiVo3 was a randomized phase 3 study of tivozanib versus sorafenib in patients who received one or more than one line of therapy, including the IO or TKI combination. So coming to the result of this study, the tivozanib versus sorafenib. So even some patients have in this study who have received the fourth line therapy were taken. And if you see this the PFS of tivozanib versus sorafenib, there is a clear benefit in the tivozanib compared to the patient who received the sorafenib. So the median progression-free survival was around 5.6 months in the tivozanib group versus around 4 months in the sorafenib group, and the progression-free survival was around. So this has established and this has got approval also based on this data. The FDA has approved this drug in second and third line beyond, but it's not available. But in due course of time, we might have one another weapon in the against the clear cell RCC. So we are just waiting for this drug to get approved in our country also. So this is another drug which is coming in a very fast way in a metastatic belzutifan. It's a HIF, that is hypoxia inducible factor 2 alpha inhibitor. So this drug has already been approved for use in a von Hippel-Lindner VHL syndrome patients to prevent the further progression of the lesions in other, like in pancreas, cerebral hemisphere, or progression of other lesion in the RCC in VHL. So this drug is it, and we all know that HIF is implicated in the pathogenesis of at least clear cell RCC. So this has drug now slowly started creeping in the management of the clear cell RCC. So this was a dose expansion study of belzutifan 120 mg in patient who progressed over multiple line of therapy. So if you see the response rate of this drug in of a advanced RCC who have received multiple line of therapy, around 1/4 patient responded with the around 25% patient of some sort of a partial response, compared. So this was a dose expansion study, and it has shown that there is definitely some efficacy of this drug even on the third and subsequent line of therapy. And now there is a one randomized trial of this. So side effect profile, it is very much manageable. Anemia and hypoxia were the more common side effects seen with this drug. So the next slide, please. So this drug has also already been put in a phase 3 trial. So this is a phase 3 trial of belzutifan versus everolimus in advanced RCC after PD-L1 and TKI. So this trial has already started, and in due course of time, and looking to the early data, this will be a positive study. The only issue is that the comparator arm, they have still continued with the everolimus compared to the other TKI, but definitely this will be one of the if this has will be due course of time, the result will tell us whether we can be able to use drugs in the third and subsequent line therapy or not. So this NCCN guideline I already discussed. The cabozantinib, lenvatinib plus everolimus, nivolumab, these are all category 1 recommendation. Axitinib is also still category 1, but this has moved into the other category recommendation. So I think this scenario is very fast changing, and we may have further therapy in the second line and beyond RCC. So this is the slide which is just showing the how the treatment has progressed over period of time. If you see the 3-year, so these are the survivors. This is the interferon era where the 3-year survival is around 10, only 10% patient used to survive. Now after that there was a TKI followed by immunotherapy. If you see this, the 3-year survival increased up to around 40%, and with the combination of TKI plus IO in first line, this survival has increased to around 60%. And that what we are aiming, that even all patients of a metastatic RCC, this should be a flat curve. So we are gradually improving from the interferon era to the TKI followed by IO era, and now the combination of TKI plus IO era, where the 3-year survival is in the range of 60 to 70%. And with the availability of the better and newer therapy, we might see a day where the metastatic RCC will become a chronic disease with the various treatment options, and patient may live for a longer period of time. So this is the last slide. We have just seen the sunrise in the second line management of RCC. Many more options will come, and it will improve the survival for these group of the patient. Thank you.
Thank you very much, sir. That's because we have so many options, so it's more confusing at this moment of the time, because so how to choose as how to sequence is most important. What you have mentioned is, thank you very much, sir, for a wonderful talk. Now I would like to invite Dr. Vindhya Vasini. Okay, so she's a consultant in Omega Hospital, Hyderabad. Now she's going to just to speak on the key studies in metastatic renal cell carcinoma, a conference highlights from ASCO GU 2022 and ASCO. So over to you, Dr. Vindhya.
Good evening, sir. At the outset, I'd like to thank the organizers and Pfizer for giving me this opportunity to be a part of this important conclave. So I would be presenting the updates of the ASCO GU 2022, which concluded in Feb this year, and also from ASCO. So I think my presentation would be a summary of all the presentations which have taken place this evening. So these are the disclaimers. Starting from with the first presentation, this is the updated analysis of the Keynote 564 trial, which is an adjuvant pembrolizumab trial in clear cell RCC. So it included adults with clear cell RCC with intermediate high risk, or M1 NED disease. So intermediate high is defined as T2 grade 4 or sarcomatoid carcinomas. High risk included T3, T4 lesions, any grade, and M1 NED is oligometastatic disease with metastasectomy done post within 1 year of nephrectomy and with no evidence of disease. Here, brain and bone mets were excluded from the study, and the surgery should have taken place within 12 weeks before randomization with no prior systemic therapy. Tissue samples were available for PDL1 evaluation and the patients had performance status 0 to 1. They were randomized 1:1 to pembrolizumab 200 mg once in 3 weeks for around 17 cycles, that is up to 1 year, versus placebo. The stratification was based on the metastatic status, M1 versus M1 NED. And the primary endpoint was investigator assessed disease-free survival, which was presented in 2021 ASCO. And the primary endpoint was met in the first interim analysis presented last year. So when we look at the key secondary endpoint, which is overall survival, which is not met yet, and other secondary endpoint was safety. When we look at the median disease-free survival in the first interim analysis presented last year, the hazard ratio was 0.68, favoring pembrolizumab. That is a 32% reduction in the risk of recurrence of disease, with a median follow-up of 24.1 months. So this is the baseline characteristics. When we look at the pembrolizumab and the placebo arm, they are well matched. Median age was 60 years, with majority 70% being males, and around 80% had intermediate high risk category, and 10% of the patients were having sarcomatoid features. When we look at the PD-L1 status, 25% of the patients had CPS less than 1, and around 44% to around 60% had tumor grade 3 or 4, and around 5% of the patients had M1 NED. So this is the DFS primary analysis endpoint. This is in last year 24-month follow-up was presented. Now they have presented the updated 30-month follow-up analysis. They have observed that after a longer follow-up, there is an persistent disease-free survival benefit with adjuvant pembrolizumab with a hazard ratio of 0.63. When we look at the previous hazard ratio, it is 0.68, and now the hazard ratio is even improved with longer follow-up, favoring pembrolizumab. When we look at the subgroups, in the pre-specified subgroups, be it the intermediate high risk or M1 NED, all the subgroups based according to the risk categorization benefited with pembrolizumab, with high risk and M1 NED subgroups having the maximum benefit. When we look at the hazard ratios in the M1 NED category, it was 0.28, though the numbers are low. Nonetheless, it was significant. And even in patients who had sarcomatoid features, pembrolizumab had even greater improvement, showed even greater improvement in the 24-month disease-free survival of 71.8% versus 52 in the placebo arm, showing with a hazard ratio of 0.54. And the others concluded that adjuvant pembrolizumab improved the disease-free survival across subgroups, including those defined by recurrence risk, sarcomatoid features, and PD-L1 CPS. So when we look at the overall survival data, the overall survival at 24, the primary analysis, that is the first interim analysis presented last year, showed 96.6% 24-month OS rate in the pembrolizumab arm versus 93.5 in the placebo arm. And in the updated analysis, it was similar, which was maintained at 96.2% in the Pembro versus 93.8% in the placebo arm. But the hazard ratios did not cross the pre-specified boundary for significance. So there is no significant difference in OS observed between the treatment arms in the primary and the updated analysis, but the OS data is still immature. And this updated analysis had accrued 66 OS events, whereas the final analysis is planned after 200 OS events. When we look at the safety analysis in the as treated population, when compared to the interim analysis presented last year, the updated analysis did not show any new safety signals. All cause adverse events were seen in 96% of the patients, 96.3% of patients in the pembrolizumab arm versus 91.1 to 0.3% in the placebo arm. Grade 3 to 4 toxicities were seen in around 32.4% in the pembrolizumab arm, and in the updated analysis, the number is maintained at 32.2%. And adverse events leading to treatment discontinuations were seen in around 21% of the patients in the updated arm, which was similar to last year. And adverse events leading to death was seen in 0.4%. When we look at the treatment related adverse events, the interim primary analysis and the updated analysis showed similar toxicities and grade 3 toxicities and treatment toxicities leading to treatment discontinuation. When we look at the immune related adverse events, no new immune adverse events were reported. Grade 3 and 4 adverse events were seen in 8.6% of patients on pembrolizumab at 24-month follow-up, which was 8.8 at 30-month follow-up. And the patients requiring high dose corticosteroids for the management of these immune related adverse events, it was around 7.4% last year. Now, after 30 months of follow up, it is 7.6. So the authors concluded that pembrolizumab arm exhibited higher rates of grade 3 and 4 adverse events, treatment discontinuations, and systemic corticosteroid use to treat the immune related adverse events. And when we look at the various treatment related adverse events incidence more than 5% in the population, we see that fatigue, pruritus, hypothyroidism, diarrhea, rash, and hyperthyroidism are more common in the pembrolizumab arm, with grade 3 diarrhea, rash, and fatigue being the most common grade 3 events in pembrolizumab arm. When we look at the median time to first onset of the toxicity in the pembrolizumab arm, we see that majority of the adverse events occur within the first few weeks of start of therapy, with hyperthyroidism being initial, the median time to presentation of hyperthyroidism being around 3.1 months, which later progresses to hypothyroidism. Pruritus, fatigue, nausea start earlier on, and majority of the adverse events, toxicities occur within 3 weeks to 12 weeks from the start of therapy. So the investigators concluded that in this updated analysis, adjuvant pembrolizumab maintained a statistically significant disease-free survival improvement over placebo in patients with RCC post-nephrectomy, and the updated hazard ratio for DFS was 0.63, which was even better than the last previous primary analysis, which was where the hazard ratio was 0.68. And the benefit was consistent across patient subgroups based on the risk categories and the sarcomatoid features and PDL1 status. And OS data is still immature in this update analysis, and additional follow-up is planned. And with longer follow-up, adjuvant pembrolizumab was not associated with any increases in the adverse events or use of high-dose corticosteroids. And very few adverse events had late onset. And the investigators concluded that updated analysis supports use of adjuvant pembrolizumab as a new standard of care for patients with RCC for recurrence. So that is the first presentation. The next abstract is the NEO-AVAX trial, which evaluated the role of avelumab plus axitinib in the neoadjuvant setting in patients with localized RCC who are at high risk of relapse after nephrectomy. This present abstract presented the efficacy, safety, and biomarker analysis of this trial. So, NeoAVAX trial is a phase 2 trial which um, enrolled patients with clinically high risk clear cell RCC who with a good performance status and no comorbidities that preclude surgery or systemic therapy. And patients, the definition of high risk was the standard which is used in all other trials. And uh, 12 weeks of neoadjuvant avelumab and axitinib was given prior to nephrectomy. Axitinib was given 5 to 10 mg BD, and surgery was not done earlier than 36 hours after last axitinib. And avelumab was given at 10 mg per kg IV every 2 weeks. And the primary endpoint of this study was the partial response in the primary tumor in more than 25% of the patients. And to demonstrate this effect, 40 patients were required uh, with an alpha of 0.05 and a power of 80%. And when we look at the key results, uh, 12 patients, that is 30% of the patients, had a partial response of their primary tumor, and of the 12 patients, 10, that is 83%, has had disease free, were disease free. When we look at the treatment related adverse events according to the frequency, the most common adverse events were hypertension, followed by infusion related reactions, fatigue, hyperthyroidism, mucositis, diarrhea, hypothyroidism, nausea, hand-foot syndrome. The most common grade 3 toxicities were hypertension, infusion-related reactions, which were seen in 2 patients, fatigue, nausea, hand-foot syndrome, and elevated liver enzymes were seen in 1 patient each. And also, biomarker analysis was one of the exploratory endpoints which was done on sequential paid tissue samples on pre-treatment biopsy and nephrectomy specimens. And they have evaluated PDL1, CD8 positive cells, CD8 negative, granzyme positive T cells, FOX P3 positive cells, CD8 and CD39 positive, and MHC1 on these samples. And they found that in patients who had recurrence, the tumors had lower densities of total intraepithelial and stromal CD8 positive and intraepithelial CD8 positive, CD39 positive cells. Clearly indicating that this could be biomarkers which could be later on used in other trials to evaluate the further treatment. So, coming to the next update presentation, this is the keynote 426, which evaluated the role of pembrolizumab plus axitinib versus sunitinib as first-line therapy in advanced RCC. So here in the present in the update presented in the ASCO GU 2022, the authors presented the analysis of progression-free progression after first subsequent therapy. So when we look at the study design, the objective of this presentation was to present the PFS2 and subsequent therapy used in the intention to treat population and in international metastatic RCC data IMDC risk subgroups. So progression-free survival 2 PFS2 was defined as the time from randomization to progression after first subsequent therapy or any death due to any cause, whichever occurred first. And the trial included newly diagnosed stage 4 clear cell RCC or recurrent disease with no previous systemic treatment for advanced disease with measurable disease. And risk stratification was based on the IMDC risk group, favorable versus intermediate versus poor, and the region. They were randomized 1:1 to pembrolizumab 200 mg once in 3 weeks up to 35 cycles, that is approximately 2 years, plus axitinib 5 mg orally. Axitinib dose was titrated based on the tolerability. It was increased to 7 or 10 mg or reduced to 3 and 2 mg if toxicity was high. The comparator arm was sunitinib, 50 mg orally once daily for 4 weeks of each 6-week cycle. It had dual primary endpoints of overall survival and progression-free survival in ITT population. And the key secondary endpoint was objective response rate in the intent to treat population, other secondary endpoints being duration of response and safety. A post hoc and exploratory analysis was done for PFS2 in the ITT population, which was presented in this update. So when we look at the baseline demographics, they are fairly well matched. Median age was 62 to 60, 61 to 62, with 70% to 75% being males. Europe, Western Europe, North America, and other regions of the world were included. Around 68% of the patients had intermediate poor risk disease, and around 70 to 77% of the patients had more than 2 metastatic sites. And majority of the patients, that is around 82% of the patients, received nephrectomy. When we look at the first subsequent anti-cancer therapy, patients who progressed after pembrolizumab plus axitinib.
Sorry to disturb you, Dr. Vindhya. Just time
Yes,
is up. Just 1 minute, last 1 minute. Okay.
1
Sorry.
minute, sir. Oh,
Last.
okay.
Okay. Okay. Sorry.
Majority of the patients went on to receive VEGF or VEGF receptor inhibitors, whereas patients in the sunitinib arm received PDL1 or PD1 inhibitors. So this is the PFS2 data, which showed that at the um, uh, for post progression, the median PFS2 in the pembrolizumab arm was 40 months versus 27 in the sunitinib group. And this was seen in both the favorable and the intermediate risk group. So others concluded that uh, long-term results continue to support pembrolizumab plus axitinib um, in the patients, and PFS2 was longer for patients with pembrolizumab plus axitinib group than for those in the sunitinib group. So this is the real world data which was presented from UK, and they have shown that avelumab plus axitinib in first line advanced RCC has reflected the trial results reflected the results similar to the trial data. And this is another poster presentation on Checkmate 9 ER, which showed the final overall survival analysis. And the authors concluded that Nivo plus cabozantinib provided improved survival versus sunitinib in the final OS analysis, and no new safety signals emerged. Another presentation of the Checkmate 214 evaluated efficacy and safety of Nivo plus EP versus sunitinib, and it was a post hoc exploratory analysis of efficacy and safety, and the authors concluded that clinically meaningful efficacy benefits were observed in Nivo EP arm versus sunitinib and were maintained over 5 years regardless of the PDL1 expression, and the results support use of Nivo EP in intermediate and poor risk sarcomatoid RCC, a population with unmet need. And this is an updated analysis of the CLEAR trial, which evaluated lenvatinib plus pembrolizumab, and it showed that efficacy result. They evaluated its efficacy in East Asian population, and the results mirrored the original trial data. And finally, this is the updates on the various clinical trials in first-line metastatic RCC plus novel pathways. And this was presented by Dr. Vaishampayan. They have initially now we know that PDL1 inhibitors and IO combination, or IO plus TKI combination, is the first line. And in when we use these combinations, Long-term overall survival is considered the ideal endpoint, especially when we look at the Checkmate 214. The PFS is not different between the two arms, but it is not the overall survival is better in the IO arm. And they have evaluated novel biomarkers, be it the interleukin pathway or the hypoxia-inducible pathway, which would be the future way in which next wave of clinical trials in RCC would be conducted. So to summarize, longer-term follow-up of the Checkmate 9ER supports use of cabozantinib and nivo as first line. Then treating patients with sarcomatous RCC with IO is supported by longer follow-up of the Checkmate 214, and East Asian population has clear benefits with the combination as seen in the final trial. And the updated Checkmate 9ER efficacy data do not separate itself from what is seen in the Keynote 246 trial. And novel mechanism of action of drugs are in development and hope to maintain the efficacy seen with the doublets while improving the tolerability.
Yeah, thank you, Dr. Vindhya
Yeah.
Vasani. I think a little bit rushed and last
Yes.
minute
Thank you.
because
Thank you so much, sir, for
you
giving me.
wonderful, I
This is
think,
the last slide. Yeah.
yeah, wonderful exposition of this all the trials. Okay. Now I would like to request Dr. Chandrakant. He's a consultant medical oncologist at Narayana Super Specialty Hospital, West Bengal. So he's going to have something case presentation and some of the Indian perspective critical analysis of this case. Over to you, Dr. Chandrakant.
So I would thank the organizers and Sadashiv sir for the kind introduction and for the opportunity. So this is my one of the early experiences of avelumab plus axitinib combination in metastatic renal cell cancer. So I will present my case and with the justification as to why I chose avelumab plus axitinib in this particular patient. So to begin, here is a 52-year-old gentleman who is known to our own, one of the staffs where I work in RN Tagore Hospital, is a hypertensive and diabetic with 15 years of smoking, 15 smoke years, and also has COPD. He presented in Jan 2022 with a 3 months history of multiple symptoms of lumbar pain, hematuria, swelling in feet, dry cough, weight loss by 5 to 6 kgs, and he also had a low grade fever, undergoing multiple courses of antibiotics for UTI and so on. So, with this history, when he came to us, when we examined him, he had a sort of a performance status 2 ECOG. He was a little obese with a BMI crossing 27. Otherwise, his vitals were stable. He did have pallor and he had pedal edema and he had a large renal mass, in the right lumbar region. So he looked little unwell for us, and with this in the background, the baseline investigations did reveal low hemoglobin levels, and you can see the creatinine also being around borderline of 1.3 with borderline raised calcium levels. Otherwise, well preserved with a higher level of LDH, and there were plenty of uh, RBCs in urine. So with this, in the present day, we saw all the presentations. The moment we get a metastatic RCC, these risk scoring are no longer prognostic; they are even predictive of therapy. So when we looked into the IMDC risk scoring, just to say that even before imaging the patient, knowing the exact site or the target lesions, we can risk score just to understand how fast the disease is going to multiply. And if you could see that, this patient had 4 risk factors, had a short history from diagnosis to become eligible for treatment, had a compromised performance status, had high neutrophil count. With all these risk factors, he had 4 risk factors, and you can look the survival in a poor risk is less than a year before the IO era. So with this, we did counsel the patient regarding the outcomes, and we did a PET CT. The PET CT, you can just see these images. There is a large, 9 to 10 centimeter large kidney mass on the right side. There are multiple lung nodules. The patient was symptomatic, and very importantly, he had sort of a paraneoplastic fever, low grade fever, with a history of receiving multiple courses of antibiotics. So we did a CT guided biopsy from the renal mass. It was clear cell carcinoma, and there were no sarcomatoid features, and it was Fuhrmann grade 2. And we did confirm the clear cell by IHC2. So with this, the final diagnosis became it's a metastatic clear cell RCC, poor risk with 4 risk factors with a large right renal mass, and there was IVC thrombus, multiple lung nodules, and there was also a L1, L2 vertebral mets. He had fever at baseline, poor risk metastatic RCC with a compromised performance status. So we explained the patient regarding the palliative intent, prognosis, the treatment options. It's very difficult to explain in the present day where you have so many options of IO, TKI, TKI mono, everything. And very importantly, what is the patient assistance programs available for the IO molecules in the present day? These also become important. So, well, this is an important slide. So, in the first line, when I think of a TKI, which TKI should I choose becomes a challenge. We have cabozantinib, which is extremely potent. We have lenvatinib showing excellent responses. But just look into this slide. What you can just focus on is the half-life of axitinib is the short test. The moment half-life becomes short test, the side effects rapidly reverse on stopping the drug. So you can see just 6 hours of half-life for axitinib when compared to cabozantinib or lenvatinib, it's more than a day. So that means even if you stop the drug persists in your body and the side effects continue to happen. And then you cannot differentiate whether it is IO related or whether it is a TKI related. Therefore, when you're using a combination of IO TKI, very important for rapid reversal of symptoms on stopping the drug. Therefore, I always thought that axitinib is a preferred TKI partner when compared to all other TKIs. So, going on to this little busy slide, but if you look into the right upper quadrant, the overlapping toxicity of an immune checkpoint inhibitor and a TKI is important. Both can cause diarrhea, both can cause rash. So if you have multiple targets being inhibited, for example, cabozantinib or lenvatinib, both of them can cause a lot of HFS and diarrhea. And if there are overlapping toxicities, again, you cannot differentiate whether it is IO related, whether it is TKI related, and you will end up with stopping both of them or giving steroids. So therefore, the preferred TKI combination in view of only VEGF inhibition. It's not a multi-tyrosine kinase inhibitor accident. It is very specific for VEGF, and the side effects resolve on stopping it. Therefore, axitinib becomes sort of a preferable partner with the shortest half-life. So, well, coming on to IO combination, you can just look into the initial 2 months of follow-up of Checkmate 214. You have progressive disease as the best response in around 25 to 30% patients. Therefore, when you have a patient who is grossly symptomatic, for example, symptomatic with cough, breathlessness, or pain in the abdomen, and if you have progression as the best response in the initial 3 months, it becomes a challenge. So in those set where you can see the Javelin renal study where there is early separation of curves as early as within 2 to 3 weeks. So that made me to choose a TKI combination and preferably an axitinib based combination when compared to other TKIs. So then coming on to if the moment you have axitinib, you have two options, pembrolizumab axitinib or avelumab axitinib. Well, there is specifically no head-to-head comparison between the two, but if you look into the discontinuation or the side effects that result in dose reduction and discontinuation, looks like avelumab axitinib is a much safer and easy to go regimen when compared to pembrolizumab, and very importantly, a patient assistance program sort of is better with avelumab right now in our country. So with all these in background, after counseling, patient assistance, side effect profile, which TKI, so I finally decided to give avelumab 800 milligram to weekly in combination with axitinib twice daily with zoldonic acid and calcium vitamin D supplementation. So well, the patient called back, the next day, the fever gone. So IO is somewhere you get very rapid responses. In some patients, you can see those early separation of curves. If a patient is IO sensitive, the response happens very soon. And this is one example. Fever resolved on day 2 and significant improvement in lumbar pain, back pain, hematuria subsided in 2 weeks. And then by 6 cycles, by 3 months, patient gained 5 kgs of weight, resolution of cough and hematuria, complete resolution of pain and fever, hemoglobin improved to 10.2 without any transfusion from 8.2, significant reduction in pedal edema. There was IVC thrombus, we can just recall that. So, well, we did a PET CT to evaluate. You can see these PET CT images, the upper ones or the older ones and the lower ones or the newer ones. You can see those big lung nodules showing almost near complete recovery. So the patient had prompt relief in symptoms. And you can see the lung nodules and you can see the renal mass. The upper big 8 centimeter kidney mass is shrinking to around 5 to 6 centimeter, again showing a significant response, and it has become more cystic, more necrotic, showing how well and how soon and how deep these responses can be when you use IOTK combination. Then coming on to, so this is again another image reflecting the before and after images of how well these can act. And coming on to the data of Javelin Renal 101, you can see significant percentage of patients were intermediate risk, reflecting the real world data, real world population, but even this did include a substantial number of poor risk patients. And then look into the separation of curves early and quite significant. 38% reduction in progression-free survival is quite phenomenal, either in the PDL1 population or unselected for PDL1. In both subset, you can see substantial benefit in progression-free survival. And if you look into the forest plot, irrespective of all the three risks, the hazard ratios are impressive. And that too for poor risk, you can see the hazard ratios are much more impressive. So when you place IOTKI, even in the favorable risk, we can see the benefit in all the three subsets. So this is about the duration of response, and the overall response rates are significantly better with avelumab axitinib, almost doubling of overall response rate and early response rates across all the subgroups, irrespective of the risk. And this is the duration of response. Again, the moment duration of response is the IO always is a winner, and this is an example of that. So then coming on to overall survival, whether it is PDL1 positive, whether it was PDL1 negative, was not statistically significant, but the data are immature to comment on the overall survival. But you can just look into this analysis. This is an analysis where the RPTSF analysis is where if you nullify the crossover, then it becomes quite significant. So the RPTSF analysis shows that if you can nullify the crossover, you can see the post-progression therapy in the Javelin trial. There are a significant number of patients with sunitinib receiving immunotherapy in the subsequent line, saying that if you have multiple subsequent therapies, second line, third line, fourth line therapies, it will nullify the overall survival because it will dilute the overall survival. The PFS in the first line may be excellent, but it will nullify if you have multiple subsequent therapies. And if you can nullify that crossover, the overall survival is significant. And the hazard ratio for overall survival or hazard ratio for progression-free survival is in par with the Pembro-Axi data. So therefore, there is no, probably it's more of a statistical reason why an overall survival is not there, or probably because of multiple subsequent therapies. The number of patients who receive subsequent therapy are higher in Javelin renal trial when compared to the other trials. And probably this is the reason why we are seeing a non-statistical improvement in overall survival. But if you can nullify the crossover, you are seeing a statistical significance. So with this, early experience, what I personally felt was, none of the combinations are superior or inferior. It's a case-to-case selection. We need to see whether you want early response, and you cannot afford progression in the, at least in the initial 2 months. In those set of patients, I would prefer an IO-TKI. And if a patient is really fit, young, then probably you can choose Cabo or Lenva as a partner. But if you have a patient who is frail and concerned of toxicities, then axitinib becomes a preferred partner. And then if you want axitinib being there as a TKI, where even the overlapping toxicities of IO and TKI should not be there, again, axitinib becomes a preferred TKI. And the IO partner can be anything. So we have data for Pembrolizumab, very long-term data, excellent data, and we have Avelumab-Axi. But at present, patient assistance is where made me choose this particular combination, and more above that, the number of dropouts are far better. And if I compare and contrast the cross-trial comparison, the hazard ratio of progression-free survival of Javelin versus the Pembrolizumab looks similar. And if we have the RPTSF analysis, the overall survival is significant. So with this, I would thank all of you for your patient listening, for helping me to share my early experience of Avelumab and the poor risk metastatic RCC in this elderly gentleman with multiple comorbidities. So thank you everyone for patient listening.
Yeah, thank you, wonderful, Dr. Chandrakant. I think you have shown your own experience, and you have given some examples also. Very nice presentation and good experience and sharing also. Now I would like to request Dr. Prasad Narayanan. So for the final discussion, I think I would like to request all the speakers of the previous talks from Dr. Mohit Agarwal, Dr. Amit Joshi, Dr. Chandrakant, Dr. Ravi Tippeswamy, Dr. Ashish Singh, Dr. Vindhyavasini, and our guest speaker is Dr. Ender Grande to invite this panel discussion. Over to you, Dr. Prasad Narayanan.
Good evening. Thanks for the opportunity. So, this is the disclaimer for the presentation. We have had an exhaustive discussion. I would not go into a detailed panel discussion with any case based. I think since we didn't have any question answer opportunity after the talks, maybe I thought we will try to bring out the gist of everyone's presentation and share some basic Monday morning kind of practice situation. We saw this slide in the presentation before that we are spoiled with choice in metastatic RCC, and Dr. Sadashivudu was starting to say that when even I can share that when we had started practice, we were left with very little options in metastatic RCC. So we will start this. Maybe I can ask this question to Dr. Mohit because he presented the landscape for first line therapy. Dr. Mohit, what is your, if you want to choose the most important features which you consider before starting treatment, can you just mention your comments on that? Choosing first line therapy. Dr. Mohit is there or?
No, sir. He has some technical issues. He's trying to join.
Then I think I will request Dr. Hendrik to take this question because he gave us a very good perspective about how to choose a patient. Dr. Hendrik, can you take this question, please?
All of this, I think we should consider all of this. If you are asking for the most important one, I would say patient by patient, we need to discuss.
Right. So, which is, you said that there are some patients where we can, or before you take, I ask you this question, let me run this question through my Indian colleagues actually. In your practice in India, what percent of the patients get first line immunotherapy? We can start with Chandrakant.
So in the present day, around 20% in my practice.
20%. Okay. Dr. Vindhyavasini, I don't think she's there. Is Dr. Ravi Tippeswamy and Dr. Ashish there?
Yeah, I think it is similar. About 1 in 5 or 1 in 4 will choose.
And Ashish?
Yeah, I'll say now with data available with most of the molecules, and at least to begin with, about 30 to 40% would begin.
40%. So that's a situation, Dr. Henrik, in India. Maybe I would say that in my practice also it will be around 20-25%. So if you, Amit, I don't know whether he's joined. He will have large data from a large institution like Ashish. Amit is there.
Yes.
Amit, what percentage of patients in TMH will get first line immunotherapy in metastatic?
So it's around in a first line. I think it is less than 5%. If you combine both the general and private side, so that is the issue.
Right. So with this in mind, let us frame this question again. So Dr. Hendrik, if this is the situation where 80% of a country's population are not getting IO in first line. What is that? Which are those group of patients for whom a single agent TKI is first is okay to take?
First is the terms of access.
Right?
If the access is a condition in your treatment choice, well, TKI alone, well, probably is the most used regimen worldwide, I would say, including Spain. Including Spain, we don't have a public reimbursement today. We don't have any public reimbursement for a combination of a TKI plus IO. Only Nivo IP is reimbursed so far in Spain. So today in Spain, in the majority of the sites, as it happens in India, they are receiving only TKI in favorable risk.
Oh, that is news to us actually. We were assuming that most of your patients get first line. So what percentage of your patients get an immuno-oncology drug in first line?
Well, I'm lucky because I'm working in a private institution and the private insurances are covering this kind of combination. So in my practice, I would say that this is not easy to see a patient with a TKI single agent.
Right. So now we have heard and we know that TKI monotherapy is a choice in some patients, at least because of the logistic issues. Otherwise, if you have a favorable risk patient and there is no financial issue, do all the panelists agree that we would prefer to give an IO plus TKI in combination to all patients? Can we take it as a drive-in message? Ashish, because you are going to debate, I know I don't want to steal your thunder. So, Dr. Amit, if there is no question of finance, do you think that IO plus TKI is the first line therapy for all patients regardless of risk?
I think, barring a very few subgroup of the patient where the minimal metastatic disease, like a few here and there lung nodule, which we can observe or TKI. Otherwise, the finance is not a constraint. I think with the available data, I will prefer some or other TKI, Pembrolizumab or Nivo, Cabo, because those have also shown some benefit in the good risk also.
Got it. Got it. So, Chandrakant, we heard your case presentation and we know the real situation. So, among the available TKI monotherapies, do you have any preferable monotherapy choice in first line? And if yes, why?
So in my first line, if it's a favorable risk, I would use something like a sunitinib or a pazupanib in the front line setting. If it's intermediate poor risk, then if I have to use TKI mono, I would use cabozantinib.
As a first line option.
Yes.
Right. So, Professor Hendrik, your comment on that? Any preferred single agent TKI?
Of course, if there is no access to combinations based on immunotherapy, I fully agree with that. Sunitinib could be the best choice for patients with favorable risk and maybe Cabo for patients with intermediate and poor risk. In addition to that, papillary histology is definitely Cabo should be the driver here. And of course, when you asked before, if there is any patient that probably cannot benefit from a from a combination with an immune oncology drug, probably those patients with immune-related disease. And don't forget that we have many patients with heavy psoriasis or patients with arthritis, immune-related arthritis, that cannot receive immune oncology drugs.
Sure. So, I think we'll move on. I think that message is very clear. Now we come to the next question of IO plus TKI versus a combination of IO plus IO. We know these are the available options and all of them we heard in detail about the pros and cons of this. But for a Monday morning practice, we saw this graph being shown by Chandrakant and why he chose a combination of TKI plus IO in the first line because of the early separation. I want this point to be discussed by all the panelists, starting with Dr. Amit. Do you choose this option of IO plus IO versus IO TKI based on this early separation versus late separation thing? How important is that for you?
I think in a day-to-day practice, I think that everyone I think agrees with that. That in patients who are having a lot of symptomatic disease,
where we want the early response and patient with bony compression with multiple liver metastasis, I think we will like to go ahead with IO plus TKI. In other group of the patient where the disease volume is not too high, patient is minimally asymptomatic for the disease, young fit patient where we want a long term control and possibly a cure, I will like to. So in a patient with the minimal symptomatic disease falling in intermediate and poor risk, will prefer the IO plus IO, otherwise IO plus TKI will be the preferred choice.
Dr. Ravi, if I can ask you this question, do you choose patients based on this early versus or the need for an early response, or you are okay with an IO-IO combination for the long-term separation which we see?
Yeah, I agree with what Dr. Amisar has told, and especially if the patient is very symptomatic and say paraspinal meds or something where neurological involvement is there, I prefer TKI plus IO combination instead of IO.
So I think all the panelists are joining in this. There is nobody who wants to take a different stand here. So we come to Dr. Hendrik's presentation again, and he was very clear that his choice of a TKI with IO will be axitinib, right? Dr. Hendrik, can you just highlight on this point again, so that there are many students who are attending this session now as well, about the choice of TKI as first line in combination with IO based on the dropouts and the dose reductions which we see in these trials?
It depends on what is the clinical goal that you have, that you want in your patient. If you want a response, and the response is the driver, is the treatment decision driver, well, probably lenvatinib, cabozantinib combinations are more potent because more response rate will be able to be offered to the patient. But if you want good tolerability in a long term, well, definitely axitinib is the more potent, selective, and better tolerated TKI to be combined with an immune oncology drug. This is the issue here.
Sure. I think that message is very clear. And now I will come to Amit. Amit, when we say this, that axitinib is the preferred TKI, do you have a concern of not using cabozantinib or lenvatinib in first line because you want to use them in second line as well? Because you presented the second line data.
So I think whatever the little bit clinical experience I had with Nivo and Cabo, I think the toxicity sometimes it's very difficult to manage. If you ask me, among all three combinations, which is the most patient friendly, I think Pembro XZ will be the top, followed by Pembro plus Len, followed by Nivo plus cabozantinib. So I will like to go ahead with either Pembro XC or Pembro Len, as Dr. Ergun had presented that the axitinib among all. So I, in a patient, otherwise I will prefer Pembro XC. Some patient where the disease volume is low, I can prefer, but Nivo and cabozantinib, I don't personally prefer. And that is one reason which you told me, the second line option.
Right. So Dr. Ashish, any comments on this?
I agree. I mean, even though these newer TKIs are the next generation or more potent ones, but if you compare them, they are probably lesser toxic, especially even compared to pazopanib and sunitinib, especially the axitinib and lenvatinib. It's just you have to find the right dose.
Right. So the message from the combination of TKI plus IO is very clear here, that it depends upon the patient profile, and to decide on IO plus IO versus a TKI plus IO, maybe the initial response and to avoid an early progression of disease in patients who are symptomatic with high volume, a TKI plus IO is the preferred option. And the preferred TKI, as we heard from all the panelists and the experts, it is an axitinib because of specific reasons which we heard in the previous presentation. Now we come to something which we have not discussed in the presentation, and that is about the role of, because now we have some data. Is Dr. Vindhya Vasani there, or she is not there in the panel? Anyway, so there is this role of adjuvant immunotherapy. We saw the keynote 564 data. We don't know whether the overall survival data will be coming, or whether we can't say that now. So what do you think, that if you have a patient who gets an adjuvant immunotherapy, and now the patient develops a metastatic disease later. How will this, how do you foresee the landscape change now in metastatic RCC? We can start with Dr. Hendrik on this question.
This is not easy to address this question. This is a very important question that we will have as soon as we are starting to offer Pembro. Well, probably the timing is important when the patient is progressing after they finish the adjuvant pembrolizumab. Because if they are progressing during Pembro adjuvant, well, probably and definitely we will go for a single agent TKI. Probably Cabo would be the driver here. But if the patient is progressing after more than 2 years since they finish Pembro or since they start Pembro, well, probably a combination based on immunotherapy will be also important. So timing is important. The thing is, okay, in between 1 and 12 months, what are we doing on these patients?
Right, got it. Very clear. Dr. Amit, if I can ask you, what is your percentage of patients who get adjuvant therapy in renal cell cancer?
So till now, till the approval, I think only 2 or 3, not more than that. Because we have advised to few, but actually delivering immunotherapy in our setup, so because the data has come, and I personally feel that the real benefit for this adjuvant immunotherapy will lie to the patient of a M1 NED, that is post metastectomy, and it's now currently M0, and those who are a sarcomatoid or a grade 4. So for a T3 N0, I do not usually push for the adjuvant immunotherapy. So it's until unless it's a M1 NED status or a patient with a sarcomatoid with NET, that where I push for, or I consider for adjuvant immuno.
Ashish, you are also from high volume center. Any experience of adjuvant immuno?
Yes, so again, agree totally with Dr. Amit. I mean, we all look at what is the chances of relapse in the next 2 to 3 years, and that's the highest in M1 NED group of patients or heavily node positive patients. So in those patients, I think we still don't know whether we are curing anybody, but clearly we are delaying relapses.
Right. So I think we answered this next question briefly before. So we'll again come to Dr. Amit. He presented the second line subsequent data. So Dr. Amit, do you think that the choice of a first line therapy should be based on what to give in second line, or the best option should be given first line in RCC?
I think with the availability of the long-term data of all these first-line therapy, I think we should look towards the best first line, because even if you are using the one drug, the other option for a different drug is already available in the second line. If we have used the cabozantinib in first line, then we have a len plus abro. If we are using the pem plus len first line, then we have a cabo for second line. So I think we should focus on the first line therapy more, rather than, because the options are available at least currently.
Right. So, Dr. Henrik, what is your second line treatment approach in different scenarios? A TKI IO combination progression or an IO progression, to make it simple?
Well, to start from the easiest thing, if I am using Nivo-IP in first line, definitely cabozantinib is my preferred second line option. But if I am offering a TKI plus IO, it depends on the tumor growth rate. So it depends on how rapid the tumor is progressing, how aggressive the tumor is progressing. If the patient is in good performance status, is good, patient performance status is zero, he's a young patient, no relevant medical other conditions, okay? So probably lenvatinib everolimus for those tumors that are heavily progressors, lenvatinib everolimus could be an option. If I didn't use Cabo-Nivo, Cabo after Pembro-Axi, for instance, is a good option, or Avelo-Axi is a good option as well. If the tumor is growing slowly, if I didn't offer for axitinib in first line, and if the patient has comorbidities or the deterioration of the patient is reliable, well, probably axitinib single agent can be also a good option.
Sure, very clear. Dr. Chandrakant, your experience or your comments on second line options?
No, I think Enric already said what has to be said. So I agree with similar lines. What I have not used in first line. So before we conclude, I have one question. So if you take a patient in whom we can afford progression, not a bulky disease, intermediate poor risk. If I take IO, NIVO, EP versus IO TKI, I somewhat feel that I mean, the quality of life is little better, because the TK has to go on and on and on for quite long time. So I can just get away with EP in the first 2-3 months, and after that it's only Nivo, and those who do not progress have an excellent quality of life. So how do you look at IO, looking at the quality of life of these patients in the intermediate POTUS versus IO TKI? And my second question is, where do you put avelumab axitinib? That is the talk. So how do you put that in the present data where we have pembrolizumab, pembro, Axi. So these are the two questions which I have before we conclude.
So Dr. Henrik and followed by Dr. Amit to take these questions, please.
There are two patient profiles in which I am thinking on Abeloaxi. The first one, patients with favorable risk, very good favorable risk, in which, because of any reason, I want to follow up in a more close way. I mean, those patients with good risk, but older patients, or patients with other comorbidities. Patients with good risk, but a lot of co-medications, things like that, in which avelumab given every 2 weeks is important, because I want to really visit the patients closely. So I want to do a follow-up, a close follow-up to these patients. So this is one scenario. The other scenario, patients with poor risk, but with a lot of comorbidities, in which I cannot really offer for cabo nivo, lemba pembro, nivo ipi because of these comorbidities. So I want an active combination, well tolerated for those patients. So these are the two scenarios in which I am offering Abeloax in my practice.
Sure. Dr. Amit, final comments from you, and then I will.
Yeah, so it's not the comment, it's just the question to Dr. Henry. What is the reason why the OS data has not been published for avelumab plus axitinib, since the primary paper was published I think 3-4 years back. So is there anything that makes us some, is there any reason? Because by the time the event must have happened. So that is one thing. Second thing is that the only problem or only issue which I see is whenever we are classifying patient on IMDC risk stratification, it has not taken account the volume of the disease and the organ involvement, though indirectly they may affect. But a patient, even if we fall in the intermediate group with the liver metastasis, they don't do well. So what is Dr. Henry's comment on these two issues? The fallacy of the IMDC not taking the volume and the type of involved organs.
Very good questions, both of them. Well, first, Abeloaxi, the Javelin Renal 101, has not yet reported the final OS analysis. Don't ask me why. Don't ask me why, because I'm not part of the investigators of the trial. But they didn't report the final OS analysis. This is true, that, as it was said before, that the PFS2 goes in a good direction. So this PFS2, PFS1 followed by the PFS2, is offering for a very good hazard ratio 0.5, 0.6, which I think it is clinically relevant. And for me, don't forget that the primary endpoint of the trial was PFS. So the trial is positive. So the only thing is that the OS has not yet been reported. The thing why it is not yet statistically significant is very easy for me. The standard comparator arm, sunitinib in the Javelin Renal 101 trial, did it the best that in any other phase 3 trial. So the percentage of patients alive after 1 year, after 2 years is the best rate compared with any other trials before. Why is that? I don't really know. In addition to the second question about the tumor volume, I fully agree with you. Tumor volume and location of metastasis. Take a look at this scenario. You have a young lady in front of you, 40 years old. ECOG 0. ECOG 0, perfect. Platelets levels, neutrophils, calcium levels, LDH, everything is perfect. Micronodules in the lung, only micronodules in the lung, and some lymph nodes in the retroperitoneum. Okay, kidney has been removed, and now you are staging the patient and has brain metastasis. This patient, according to Motzer criteria, according to Hens criteria, is a favorable risk. Do you really think that this patient with brain metastasis has a good risk? Probably not. So location of metastases are important, and the size of the metastasis, the tumor volume, is also important. This is what when I have a resident, when I have a fellow together with me, I say, okay, you have the algorithms, you have the guidelines, and you need to know the guidelines, you need to follow the algorithms. This is great, but at the same time, you need to use the common sense. And the common sense is telling us that these kind of patients, well, probably the prognosis is different. Thank you.
Thank you.
Thank you very much, sir, for wonderful panel discussion. Ultimately, his message is common sense is most important. So that's a wonderful message I think we got. Now I'd like to hand over this podium to Dr. Kumar Prabhash, sir. So he's the head of Department of Medical Oncology, Tata Memorial Hospital, Mumbai. So the next is going to handle this debate. So over to you, Dr. Kumar Prabhash, sir.
So we had a wonderful lectures, and I'm sure all of us have learned a lot. At the outset, I thank the organizers and especially Sadashiv for kind introduction. Now we have a interesting debate, and debate is on the topic for immune checkpoint inhibitor combination versus TKI alone in first line setting for favorable IMDC risk for advanced renal cell cancer patients. And we just learned that also don't go by IMDC alone always, but let's see what we learn in this debate. In this debate for the topic, and my understanding it means Ashish will be talking for IO combination for these patients, and let's see what he teaches. Ashish, floor is yours.
Thank you, sir. Thank you for the invitation. The topic for today is we are talking about a small subgroup of patients with metastatic clear cell RCC, which we are calling them as good risk. Now, the panel discussion which just followed actually brought this out very nicely that are these patients really good risk? How are we going to classify them? The IMDC risk stratification. So there's an example of a patient on your screen. When you look at this patient, this is the run-of-the-mill patients which we usually have. A young male who has had a diagnosis 9 months ago, presents with metastatic disease and a low hemoglobin. But if you do a risk stratification, this is clearly not a low risk patient. Now, even if the hemoglobin was normal, still he will not be a good risk patient. So by good risk, we mean that patient should be 0 on all these 5 parameters. Now, why do we call them good risk? Because this was developed almost 20 years ago initially by MSKCC, later modified by IMDC. Does this still hold true in today's day when we have immuno-oncology drugs? And what about these? Why do we not are planning not to be too aggressive with good risk patients? Is it because they don't die of their disease? If you look at these curves, even these are older curves, but you still see at about 2 years, 25% of these people will die of their disease. And also the point about the volume of disease, the site of organ involvement, these are not even discussed in this risk stratification, and which we all agree that in within this good risk group, there are patients who are dying of cancer, and within this good risk group, we need better treatment. Now, also on the other hand, we all know that a small group of these patients can probably do well even without any treatment. So those are the ones which are probably the remaining 75%, where we don't have to jump and treat them upfront. Imagine if someone decides to give them a TKI upfront. What about the toxicity? What about the cost? What about the quality of life detriment? And I'm not saying that a lot of these patients can be observed. These are proven in these observation studies, where again these are not randomized trials, so the curves will, you have to interpret it differently. These are patients where the physicians felt comfortable observing, and they showed that the physicians were very good in making that decisions, and the median growth rate of many of these tumors were as low as only just 0.09 centimeter every month. And so within this good risk group, What I'm trying to argue is that there is a group of patients who does not require any treatment, and you will be doing injustice if you start them on a TKI. If you do this alone, you will probably separate off the remaining patients who require treatment. And when they require treatment, that's usually when they are progressing or when they have involvement of the liver or the brain, high volume disease. And in those patients, I think you will be doing a bigger injustice if you do not start them on the most effective therapy. Now, if a patient is sitting in front of you and he's asking you, doctor, what is the goal? What is the most effective therapy? Now, obviously, we all will want a treatment which will provide durable control of cancer. When I say durable control of cancer, we talk about the response rate and the progression-free survival, right? And we all know what is the progression-free survival and the response rates of single agent TKI in this disease. If you look at the sunitinib versus pazopanib trial, the response rate was 25 to 30%. PFS was 8 months, 9 months. Is that durable? Clearly not. Now, also, when we are talking about good risk patients, a lot of our patients will have small volume disease which are amenable to ablative treatment, even in spite of patients having metastatic disease. So when we have a patient like this, do you really want to hold on to your best treatment option and just give them a TKI? Try talking to a patient who has got a solitary lung nodule and you say, okay, let's treat you and we will do metastatectomy at a later point because you have few metastases, but we will not give you IO. Do you think that patient will agree? Right? And are you going to tell him that your median overall survival is going to be 48 months, even with TKI alone? So the patient will ask you, is this 48 months? Do I need to take the pazopanib or sunitinib for 48 months? Do these patients take these TKIs for so long? Obviously, the answer is no. The median overall survival, when you talk about, also accounts for subsequent lines of treatment. And it also accounts for local ablative treatment. It also accounts for metastatectomy, stereotactic body radiation, whole brain radiation, and a lot of other things. So overall survival, looking at the Kaplan-Meier curve, on these trials, which is again, in our opinion, not classifying these patients, classifying these patients based on the IMDC risk factor is not an apt thing to do for our trials. But due to lack of anything better, that is what our trials are doing, and we need to interpret these overall survival curves very carefully. Now, what about side effects of treatment? Dr. Chandrakant was mentioning he likes Nivo EP because once the 4 doses of EP is over, the risk of side effects are over, and Nivo is so better tolerated than any TKI you can think of, right? Similarly, exitinib, Dr. Enrique was saying, exitinib is a very potent VEGF inhibitor, does not have this dirty kinase toxicity, and those patients have excellent quality of life and lesser side effects. So then why do we have sunitinib and pazopanib listed as an option? This is only because they were always there earlier, and in order for the people who write these guidelines, in order for them to remove this, they have to show an improved overall survival in this favorable risk group, which the trials have not been able to show. But my argument is that in the era of immunotherapy, we should probably not have these tables written like this. We should not be having a favorable and poor intermediate risk segregation. Rather, we should be segregating them as patients who require treatment versus patients who do not require treatment, and that will be a better stratification. And so I don't think we have much time, and so let's just focus a little bit more about response rates, right? I'm showing you these graphs because when we have a patient with a good risk disease, there are a significant number of patients who may be long-term responders, and a lot of the time these long-term responders are long-term responders because of the response they have got, right? We also talked about PFS2. What is PFS2? PFS2 is response to TKI once they progressed on the first line therapy. And why is PFS2 consistently better in today in the modern era? That is because we also know that immunotherapy used upfront does have prolonged effect. There is a carryover effect. Is it because of longer half-life? Is it because these drugs are available in the tumor tissue, in the microenvironment? We do not know. So therefore, I would just conclude and I would argue that in today's era, what we all do is we first segregate patients based on patients who require treatment and patients who do not require treatment. If you have a very good risk patient, please do not treat, please observe. If you require treatment, do not hold your best options for later, because the better the disease control, the better the first line treatment, the better the survival will be. And with that, I will pass it on to Dr. Ravi.
Thank you, Dr. Ashish. We'll go ahead with the next presentation, and that will be Dr. Ravi. You will be speaking against the motion. Ravi, floor is yours.
Yeah. Yeah, thank you, sir. And I thank the organizers for giving this opportunity. I think the panel discussion had made it very clear what to choose, and so it's only a debate. So where we can use this TK alone in first line treatment, I think this is the current debate which is going on. So I think the fallacies have been extensively discussed regarding the risk stratification criteria what we use. And we all know the landscape of RCC and how it has progressed. And so bottom line is this sunitinib has been for a long duration. So almost about 2 decades, which we need to see and we need to understand. So what is the current role of single agent TKI and where do we fit? So Dr. Ashish has nicely explained how we can observe, but the point which I want to make is this IMDC criteria itself is a fallacy, which I think everybody agree. And if you see the intermediate risk, if it is 1 risk factor and 2 risk factor, in most of the trials, both have been clubbed. So this is one big fallacy. And when we come to the real world practice, what we do, I think as Dr. Hendrik told and as many experts feel, in India, when we talk about talk to a patient, what we can offer, most of the time it will be a single agent TKI. So what is the evidence for that? So we have real world data also, which was published recently in Oncologist. So the fallacies we already know. Most of the clinical trials are not based on the risk stratification, apart from few trials like cabozantinib versus sunitinib or nivo-EP versus sunitinib. Otherwise, the majority of the clinical trials were based on the IMDC. So when we come to the background where we can use sunitinib, if we see the sunitinib registration trials, and if we see the favorable and intermediate, the favorable group had survival for 16 months versus intermediate was 10.7 months. This is because in intermediate, they didn't separate those with favorable intermediate and poor risk intermediate. And when we again sub-discuss the real world studies, and when we see the time to treatment discontinuation, survival and response rates, we can clearly see that those who have a favorable and good risk intermediate, a single agent sunitinib is sufficient because of the good PFS data. And coming to the objective response rate, everybody agrees that sunitinib has got a good objective response rate. And survival also we have seen because of the various registration trials for sunitinib. So this is the fallacy which I want to bring to the notice, that because majority of the trials have clubbed this intermediate risk, that is with favorable intermediate and unfavorable intermediate, that's why they're able to show the separation of the curves. If they study based on a good intermediate and poor risk intermediate, and also as we have discussed regarding the site of disease, then probably it is very difficult to see this kind of separation of the curves. So to conclude from the real world study, which was published in Oncologist, the favorable risk patients, we know that the median overall survival will be good, that is 52 months. But in this good risk intermediate also with 1 risk factor, median overall survival with sunitinib is 35 months, which we cannot neglect. So this is similar, one more real world study. It is an again ongoing observational study, which was recently published. Again, they took the same fallacy of IMDC criteria. And here they are nicely separated with one risk factor versus two risk factor. And again, they have shown that with sunitinib alone, the OS is to the tune of 34 months, which is comparable to any other IOTK combination. So again, the conclusion of the trial was in an intermediate risk with only one risk factor, the OS was very similar to the patient with favorable risk factors. So this is a subgroup of patients again, which will benefit with a single agent TKI like sunitinib. So coming to this intermediate risk group, which is very heterogeneous. So this is to be taken note for any clinician when they decide whether they want to give IO TKI versus a single agent TKI, because the heterogeneity is very wide. If you see various trials and if we divide according to the subgroup, whether the intermediate, whether they have taken only one risk factor versus two risk factor, the curves again get separated. So these are the fallacies of the recent trials, which we should notice always. So to conclude, the efficacy outcome will definitely better with the single agent sunitinib if we consider even good risk and intermediate risk with one risk factor. So how to choose? I think this was already discussed in the debate. Sunitinib has shown good efficacy in favorable group and also in intermediate with one risk factor, it has shown good outcome. So given a choice, one thing is practicality, with majority of the patients are not affordable for IO. That is, if we leave apart also, a fit patient with intermediate risk with only one risk factor, I think sunitinib still ticks all the boxes and it can be chosen in our day-to-day practice. So with this, I will conclude. Thank you.
Thank you, Dr. Ravi. Dr. Ashish, any interjection by you?
Yes, sir. So I think I stick to my points. I think there are patients who require if they're sick enough to require treatment, they need the best treatment upfront. And I almost agree that almost maybe half of these good risk patients we can just observe, and that clinical judgment is what we have. And also, I we and these are patients who are going to live for many months. Starting them upfront on a toxic TKI takes away, it does impact their quality of life, and therefore starting off with an IO TKI or a lesser toxic TKI combo, many times we can even discontinue the TKI component and just continue the IO, and that gives us a very good first line disease control.
Thank you, Dr. Ashish. And this is what we learned from in debate, that you get the data in detail, and this is what we had. And but we do know, as the end of the day, truth lies in the middle, and we did learn that how to choose those right patients for right treatment. Thank you, both of you, for a nice debate. Back to Dr. Sadashiv.
Thank you, sir. Thank you for wonderful moderation. I think ultimately they have, both of them, they have put their views in a practical way. So I think everybody says that when we have so many agents, and I think at least now we got an idea which one to use first, which one as a surveillance also one of the options nobody knows exactly. So that's what we came to know today. Yeah, there's a so thank you one and all for giving us this opportunity to what I can say chair the session and moderate this session. I would like to hand over this again the same podium to Paiso. Dr. Thank you. And
Okay, so there are no questions as such. So, sir, can you just do the closing from your side? Dr. Sadashiv?
yeah, so there are no questions. I think in the chat box also has seen just now. I think nothing. I think I'll congratulate and thank you each and every speaker. They have done a good job and they have shared their personal views as well as scientific evidence. So thank you once again for giving me this opportunity to direct this second day of this session, Agenda Urinary Tumors Conclave 2022. Definitely, it's a wonderful experience, and we learned many things. I think what we hope Monday morning, at least we can use some of this data to improve our patient care. So, thank you once again for this giving me this opportunity to share this session. I'll hand over this to the organizers once again. Thank you.
Arbaz, you are doing the vote of thanks.
So thank you to all the faculty who have joined for the Generative Urinary Tumors Conclave. We had an exciting agenda with the international speaker, Dr. Enrique, followed by the talk by Dr. Amit Joshi, Dr. Vindhya, with the updates from the ASCO GU and the ASCO 2022. Wonderful case by Dr. Chandrakant at Kolkata, and followed by a panel discussion, which was again very intriguing. And we are ending with a very live and exciting debate with good views by both the faculty members. So thank you to everyone for joining on a Saturday evening, and we look forward to your continued advocacy in the future as well. Thank you, everyone.
Thank you so
Thank you.
much.
Bye, Dr. Henry. Thank you so
Thank you,
much.
Dr. Enrique. Thank you.
Bye bye.
Thank you so much.
Thank you, sir.
Thank you.
Thank you very much, sir. Good night.